Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning to all of you. We'd like to start Bismillahir Rahmanir Rahim. Alhamdulillah wa salatu wa salamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Let me start by thanking the organizing committee, Dr. Ashraf Amir particularly, for the invitation to present to you for the second year in a row on this platform of the International Conference for Family Physicians. And our topic, as you know, is about COPD. Before we start, obviously you understand COPD is not a simple disease. It's rather a complex syndrome. There's no way we can cover the topic in about 20 or 25 minutes, so I would probably go a little fast, presenting to you the topic with emphasis on the key elements which I think are important for the primary care physicians in suspecting, diagnosing, and initiating treatment for such disease. I'm going to start with the definition of COPD put together by GOLD. That's GOLD Global Initiative for COPD, and they say the following. And I'm going to pick the colored words out of the definition because I think they have a great meaning to the primary care physician who is a frontliner. When they say it's a common, preventable, and treatable disease, what do they mean by that? A common means we have not yet diagnosed every patient with COPD, which means that we need to exert a bigger effort to identify more patients who have the classic exposure and symptoms of COPD. Number two, it is a preventable disease. Contrary to the thinking that COPD cannot be stopped, cannot be prevented, we can actually diagnose patients early on to prevent complications and to alter the course of this disease. And it's treatable as well. So even when patients are diagnosed with COPD, there are so many interventions we can do to improve their health status and overall quality of life. Now, it goes on to describe what happens. Those patients who have respiratory symptoms, whether it's cough, production of sputum, shortness of breath, or exercise limitations, those are major clues to patients who might have COPD. So it's the primary care physician's responsibility to keep an open mind and actually be vigilant for these symptoms and refer the patients to the pulmonary function lab to get the diagnosis of COPD. Now, the function lab is going to tell you that there is airflow limitation, and as we will describe now in the pathophysiology, how that happens and what it leads to. And now all of this happened because of what? Continuous prolonged exposure to noxious particles or gases that initiated an inflammatory response within the airways and the lung parenchyma, leading to alteration of the normal physiology and the normal histopathology. As you will see, a process called remodeling or changing the structure of the airways and the lung parenchyma. COPD is a very important disease because of so many things. Number one, it is becoming now the third leading cause of death across the globe. So we have to pay attention to this, global killer. Number two, the prevalence of COPD continues to rise, despite all the efforts to contain this disease. On the contrary to many other diseases like cerebrovascular accidents, coronary disease, cancer, all these diseases are on the decline, but COPD continues to rise. So there's something we're not doing. There's something that we need to do to improve containment of this disease. As a primary care physician, you're the one who's going to be suspecting COPD and making the initial diagnosis. And you pay attention to patients who present to you with respiratory symptoms, cough, sputum production, shortness of breath, exercise limitation, wheezing, when they have the typical history of exposure, especially if they are over the age of 40. And from that point on, you're going to be suspecting the pulmonary disease. You're going to be asking a lot of questions about exposures, not just to cigarettes, but and don't forget, secondhand smoking is as dangerous in developing COPD as primary smoking, and also exposures to environmental factors. There could be some genetic factors as well, like in alpha-1 antitrypsin deficiency. If there's a lot of family history of COPD at a younger age in the family, that shall trigger your suspicion as well. It is true that not every smoker develops COPD. On the average, about 20% of all smokers develop COPD. Not understood, maybe genetic factors, predisposition, and so forth. Some smokers will use this argument. When you ask them to quit smoking, they will give you examples of people who smoked till they became 100 years old and never developed COPD. And it is true. Now, the whole physiology or pathology or change with COPD has to do with the narrowing and the tightening of the airways. Not a reversible one like asthma, but some sort of a chronic remodeling of the airways that becomes tighter, more thickened, narrower lumen, which can be plugged easily by these tenacious mucus secretions, as opposed to a normal patent airway that makes ventilation so easy. There is proliferation, hypertrophy, and hyperplasia of the goblet cells, and those are the glands responsible for making mucus. So it's not surprising that COPDers have a lot of mucus, which is a big part of the problem. If you take a cross-section across the airway and the lung parenchyma, you'll find that there's inflammatory and remodeling changes, changing structure across all the layers of the airways, beginning from the lumen, which becomes narrower, as we described, into the changes in the epithelial lining of the airways, the hypertrophy, the thickening of the basement membrane, the thickening of the muscularis layer, the intense inflammatory change that is found around, let me point out here, around the airway. All these little dots are basically inflammatory cells. And in COPD, we have a lot of players. We have the eosinophils, the lymphocytes, but most importantly, the neutrophils. And if we call the asthmatic patients eosinophilic sort of inflammatory patients, then we can call COPD a neutrophilic type of inflammatory disease. This section here shows you the difference between a normal lung with very nice thin alveolar walls and very thin bronchular wall, compared to this patient with COPD who has a thickening of the lining epithelium and the basement membrane with the intense inflammatory reaction, even destruction of the alveolar walls down here, and the generation of these huge giant air spaces called emphysema. And they are obviously not contributing to any gas exchange, and that's why it's dead space. We call it dead space or wasted space. Let's see if we can play this nice video for you to show you the difference between a normal looking capillary bed, normal looking alveoli, which under normal circumstances facilitate the easy exchange of gases, oxygen and carbon dioxide out, compared to this patient here who has airway distension. You look how big and how distended these alveoli are and how destroyed the walls look, and what happens to the capillary bed. Obviously a totally different picture. So it is not surprising that these patients can proceed to hypoxemic or hypercapnic respiratory failure. Now, COPD doesn't only affect the airways, but also affects the parenchyma, like you've seen, the alveoli, but also affects the vasculature of the lung. We have a protective mechanism in the lung aiming towards improving VQ matching, and that's called vasoconstrictive reflex or hypoxemic vasoconstrictive reflex. The whole idea is if there is an area that is underventilated, we shouldn't be perfusing that area. So there's no need to send blood to areas that don't have oxygen. Well, the whole purpose of perfusion is to carry the oxygen anyway. So if there is an area that is dead space, not ventilated well, the vessels leading to that area would actually vasoconstrict. But because we have so many areas that have been affected in COPD, there is widespread vasoconstriction of the pulmonary circulation leading to pulmonary hypertension. If you keep closing vessels, then the pressure is going to rise. This rise in pressure in the pulmonary circulation is going to certainly affect the right side of the heart, which, it pumps blood through the lung circulation. And that's why you get a picture like this, hypertrophy of the right side of the heart, right ventricular hypertrophy, with the subsequent development of right ventricular heart failure and the symptoms of JVD and pedal edema, ascites, and all of that. Now, this is an inflammatory process for sure. There is a lot of cytokines involved, inflammatory cells, and those inflammatory cytokines and markers actually spill out from the lungs to affect other organs. And that's why we say COPD is a systemic disease. It's not just a disease of the lungs or the airways. It is a disease of the body. So many organs will be affected by this inflammatory cascade. The lung all of a sudden turns into a kitchen of brewing and manufacturing all these cytokines that spill out through the circulation and affect other organs. So it is not surprising to find a lot of comorbidities, whether it's heart, muscle, joint, liver, pancreatic diseases with COPD. We'll talk about hyperinflation. COPDers have a problem getting breath out, getting the air out, because the airways are not supported and they collapse prematurely. Before they empty out, the airway collapses, retaining some of the gases inside. And the more they retain, especially when they become tachypnic, because they need time to breathe out. When they become tachypnic, there is less time. Less time and less time means more gas trapping in the lungs, and the gas trapping would lead to a picture looking like this person who's hyperinflated, and that's why we say the barrel chest or the increased apial diameter is one of the characteristics and findings on COPDers. So let's talk about the physiology and how that impacts overall health status and exercise capacity in particular. Let me explain the lung volumes in this slide here, and for simplicity, we divided them into 3 different colors, although in reality there are more volumes in the lungs. But anyway, so in blue color is the FRC, that's called functional residual capacity. That represents the amount of air that remains inside the lung after you exhale. So this volume is not actually going out. It prevents the lungs from collapsing. In green is the tidal volume, and this is the air that goes in and out of the lungs when you are breathing comfortably. Inspiratory reserve in red, that's just an extra capacity to take a deeper breath if you want to. So a tidal breath will be like, if I want to use my inspiratory capacity or inspiratory reserve, I'm going to go like, so I'm taking an extra breath. When do we need to take a deeper breath? When we are exercising or when there is increased demand on the lungs to provide more oxygen or to blow off more carbon dioxide. So let's watch this movie and see what happens when this person who has healthy lungs exercises. Now, to have a bigger tidal volume, meaning the bigger green here, is going to borrow from the inspiratory reserve, which is in red, and we have no problem because we have good reserve. So the patient continues exercising without feeling short of breath. Now, the next slide is going to compare a person with COPD hyperinflation, big FRC, to a normal person. Now, this person has big lungs or big volumes of FRC in particular, and smaller reserve. Compare the reserve here to this normal lung. So when they start exercising, and let's see what happens, because they start with higher, let's work the movie here. Okay. So this person with COPD is going to embark on the inspiratory reserve, but because this reserve is small to start with, they are going to get out of breath very quickly as the reserve gets exhausted and the patient has to stop exercise. And that explains why their exercise capacity is limited, because of the hyperinflation and because of the low inspiratory reserve. And that's a common board question, by the way. They'll tell you in COPD, dynamic hyperinflation, as they exercise and they become tachypnic, they retain more gas, they trap more air, and they encroach on the inspiratory reserve. So the volume that is affected is the inspiratory reserve. Now, as a primary care physician, you're going to suspect COPD when you get one of these patients with the classic symptoms, but the diagnosis will have to be made in the pulmonary function lab. And what are you looking for in the pulmonary function lab? We're looking for post-bronchodilatory persistent type of airflow limitation. That means asthmatics are tight. When you give them bronchodilators, they probably completely or near completely reverse. COPDers might have some reversibility, but they don't completely reverse. So even post-bronchodilation, there is some sort of persistent airflow limitation, and this is what we're looking for. So post-bronchodilator reduction of FEV1 to FVC. What are these things? FEV1 is how much volume you can exhale in 1 second, compared to the forced vital capacity, which is all the air that goes in and out. If I take a deep breath in all the way and then blow it out all the way, that is my vital capacity. When I do it with force, it's called forced vital capacity. This is what we do in the pulmonary function lab. If you have healthy airways, open airways, patent, you're able to exhale at least 70% of that volume in 1 second. If you cannot do that, you have a problem. So the exhaled volume in 1 second, if it's less than 70% of the total forced vital capacity, you have an obstructive airway disease. And if you're still doing this after we give you bronchodilators in the lab, then this is more characteristic of COPD, not of asthma. This is what it looks like in the pulmonary function lab. We don't have time to go through the details, but if you see something like this on exam or on the board, this is compatible with obstructive airway disease. All right, but this is the normal flow volume curve. We can also measure lung volumes either by dilution technique, by making the patient or person inhale a gas that doesn't get absorbed inside the lung, so it remains inside the airways and the lung parenchyma, the alveoli basically. So the whole idea is we dilute the gas as it goes through the airways. We have a certain amount of gas with a certain concentration. So through the concentration change, as it dilutes itself, we will have volume 1, volume 2, concentration 1, concentration 2, a known amount. With a simple equation, we can calculate volume 2, which is the lung volumes. Only limitation of that thing is if the gas does not penetrate every single area of the lung, if there is an atelectatic area that does not allow the gas to get in, this area is not calculated in the equation, and this technique will tend to underestimate the lung volumes. It is more accurate to measure lung volumes through this technique, which is called the plethysmography or body box, which measures the same thing but through pressure changes. Measure pressure inside the airway and pressure inside the box. Again, volume 1, volume 2, pressure 1, pressure 2 gives you an equation that can resolve or give you an estimation of lung volumes more accurately because it does not take into account atelectatic areas of the lung. We can also measure diffusion capacity across the membrane that allows the gas exchange by measuring diffusion capacity of carbon monoxide. And then we have a good understanding of lung dynamics and volumes and diffusion capacity, which obviously tends to be reduced in COPD, especially if you develop emphysema. Once you start destroying the gas exchange surface, then you will develop reduction in DLCO, which is diffusion capacity to carbon monoxide. You can also get some hints from radiology. If you're doing an X-ray on a patient and you see this elongated lungs with hyperlucent areas, especially on a lateral view when the diaphragm is so flat and there is lucency behind the sternum, increased anterior-posterior diameter because of hyperinflation, all these are clues that the patient might have COPD/emphysema. But we don't necessarily need X-rays to make a diagnosis of COPD. Obviously, we said the diagnosis is made in the pulmonary lab. CAT scan, if you happen to do a CAT scan, obviously looking for something else. You could be looking for PE, looking for cancer, but you can find these incidental findings of hyperlucent areas, obviously areas that failed to empty out the gas. That's why they're hyperlucent. And we call them emphysematous areas. Emphysema of the upper lobes is in keeping with emphysema that develops secondary to cigarette smoking. Emphysema that is more predominant in the lower lobes should make you suspect alpha-1 antitrypsin deficiency. I'm not emphasizing here, I'm not advocating that we do CAT scans to diagnose COPD. That's not how we diagnose COPD. But if you happen to do the study for something else, you will see these findings. Now, in the laboratory, we confirm the diagnosis of COPD, and we also stratify the severity of the disease. Gold had put criteria, and they said that if you have some limitation, meaning what? Meaning the ratio of FEV1 to FVC is below 70%, you have an obstruction. We already agreed. If you're not able to exhale at least 70% of the inhaled volume in 1 second, then you have a problem. You have an obstructive problem. And then how bad is the obstructive problem? How severe is it? They look at the FEV1 and say, well, if it's still, above 80% of what is predicted for your age, height, and weight, then your disease is mild. But if the FEV1 falls below 80%, now you're moderate disease, as long as you stay above 50%. You fall below 50%, you're severe disease, as long as you stay above 35%. Below 35%, you're very severe. This is how Gold classifies severity of disease. Why is that important? Because they found correlation between the stage you're in. So mild will be stage 1, moderate stage 2, severe 3, and very severe will be 4. The higher the score, obviously, the more severe the disease. And they found correlation between the severity of the disease based on Gold criteria and the risk for complications, loss of lung functions, exacerbations, and mortality. So that made a lot of sense. And maybe a few years ago, that was the main base for deciding therapy. It is no longer the case. It's still useful, though. Now, we are now trying to base our therapy on more clinical-oriented criteria. What does that mean? It means symptoms and exacerbations, or risk of exacerbations. And I will explain to you. Symptoms, we're trying to find out how dyspneic the patients are. In the old days, we obviously used the New York Heart Classification for dyspnea score. It said if you are dyspneic with strenuous exercise, then this is the first degree, or the first stage of dyspnea. If you're dyspneic doing regular things and you're walking slower than others, then this is stage 2. If you are dyspneic doing like minimal things like dressing yourself or stuff, then this is stage 3. And if you're dyspneic even at rest when you're doing nothing, that's stage 4. Now, the Medical Research Council came up with very similar criteria, by the way, for dyspnea classification. And if you're beyond 2, that means you're walking slower than others, that this is significant dyspnea. And it goes on till dyspnea at rest as well. There's something also called the CAT score. CAT score focuses on symptomatology mostly. Basically the cough, the amount of phlegm you're producing, if you're missing work, if you're not sleeping well at night. So that means you have a lot of symptoms. So if you score more than 2 on the MRC or more than 10 on the CAT score, that means you are having a lot of symptoms that need to be controlled. And that indicates severity of the disease and also indicates more risk for exacerbations and development of complications. So now we are categorizing patients for therapy. Now you're in the office and you want to understand how to treat your patients, and that depends on what, who gets what. Who gets the short-acting medicine, the long-acting medicine, who gets 1 or versus 2 or 3 medications. Now we need to base that on something. And we decided, or Gold decided, that we're going to base that on both symptomatology and risk of exacerbation. So we're going to classify patient into one of the 4 different categories. On this axis here is the symptoms, and on that axis you can put 1 or 2 things. Either the Gold score or the exacerbation history or risk. So when you go this way, you got more symptoms. You go that way, you are advancing the Gold stage or increasing exacerbations. So who's the lucky person here? This square 1 here, person who has less symptoms and less exacerbations, and by Gold criteria is a mild disease, either 1 or 2, mild or moderate. Who's the worst patient here? The red box. This patient has all the symptoms, lots of symptoms, more exacerbations, and worse Gold classification 3 or 4. Obviously, this patient is going to get less treatment. This person is get the highest amount of treatment. And these 2 are kind of puzzling. This person B has a lot of symptoms because it is lying all the way to the right side of the curve that says more symptoms, but it is actually lower in terms of exacerbations or Gold criteria or Gold stage. That person doesn't have a lot of symptoms, but has either advanced Gold criteria or stage, or has a lot of exacerbations. We call them the C patients. And now we'll see how we're going to base our therapy. Now, COPD is a puzzling disease because we recognize that the Gold score or pulmonary function lab doesn't tell us all the story about COPD. We have COPD who might be in the same class but act totally differently, like these 2. And that had been recognized in the old days. People who described COPD many, many, many years ago. And when we were in medical school, we were presented with that picture, the blue bloaters and the pink puffers. The blue bloaters are those patients who are just sitting around, lazy and not doing anything and retaining CO2. That's why they call blue bloaters, because they look blue. It's cyanotic. But this person here, the pink puffer, is a person who is huffing and puffing all the time. That's why they call them puffers. He's hypoxemic all the time. He cannot even eat. That's how short of breath they are. And they used to play with us in the medical school and ask us, if you had COPD, which one of these would you prefer to be, the blue bloater or the pink puffer? And everybody said, no, the blue bloater looks ugly, it's cyanotic and lazy and sleepy, narcosed all the time. I don't want to be that person. I want to be the pink puffer. But the surprise is pink puffers die more frequently because they've exhausted all the reserve. They're living right at the edge. So the chances of getting an infection complication and dying is a lot more than the blue bloaters, even though they look uglier and they are lazy. But the preference is we end up saying, okay, well, we'll set up for the blue bloaters then. But as we advanced and we look at the morphology of the COPD, we recognize that there are so many morphological or what we call phenotypes of COPD. That means in the laboratory they might look the same, airflow limitation and exercise capacity limited, but clinically they are different people. Some of them have this emphysema hyperinflation more prominently than others. Others are on a fast track to develop infections, exacerbations. There are those types that develop cancer early on. Those who have severe pulmonary hypertension early on. So they are different type of people. And in the office now you have your patient who went to the pulmonary function lab. Now you confirmed diagnosis of COPD and you know the severity or the risk of exacerbations and you want to start treatment. Now, before you start the treatment, what are you trying to achieve? What can you promise your patient and what you should not be promising your patient? Now, we have lots of medications. We will go through them. But this is the strategy. This is my plan. These are the goals. I'm going to try to help my patient by achieving these goals for them. Number one, I would like to improve their health status. How is that possible? By reducing the symptoms. I don't want the patient coughing all the time, waking up every night, not enjoying life. Number two, I want him to be able to do more, not miss work, go out for a walk, play with his kids and grandkids. That improves overall health value or quality. Now, also reducing the risk of what? Of exacerbations. I don't want a patient ending up in the hospital all the time or in the emergency department getting antibiotics all the time. Now, also reducing exacerbations, whether it's the hospital or at home, reducing the risk of mortality and reducing the risk of complications like the development of pulmonary hypertension or cancer. So that's what I have in mind when I start therapy. Now, there are so many things we can do, starting obviously by preventing the disease by urging the patients to quit smoking. Immunizing patients regularly against the influenza vaccine every year, pneumococcal vaccine. Our mainstay of treatment is going to be some sort of an inhaler medicine. Now, there's non-pharmacologic interventions as well by taking care of the patient's diet, exercise, lifestyle, oxygen. And when the disease is so advanced, we have also non-invasive positive pressure ventilatory support. And we also have advanced interventions that we can discuss later on. Well, let's start with a simple thing, which is urging patients to quit smoking. Obviously, you are the masters of that topic, and usually all the programs to quit smoking is led by family physicians, and I applaud you for that. You know about the topic more than I can tell you in this brief presentation, but counseling, trying to convince your patient to quit smoking. The track record, unfortunately, shows that only 20% of smokers are successful in quitting smoking and sustaining that. But there is a lot of pharmacologic help and support that is available. Nicotine replacement therapy, as you can see, the patches in the gum. And there's also those medications that can reduce the urge to smoke, like bupropion and Chantix. And, whatever approach you would use with the patient to convince them to quit smoking is a great help, whether it's a religious approach or psychiatric approach or family support, society support, incentives, changing habits, getting the patient into different lifestyle, taking the focus away from smoking. All these things help. Now, we said the treatment is going to mainly be in the form of an inhaler medicine. Now, in the old days, we used oral bronchodilators, medications that opened up the bronchioles, and they were pills. Nobody uses these anymore because that's obsolete. There was a lot of side effects and less efficiency. So nowadays, using these medications, I understand I'm using the medications for the following reasons. I'm going to reduce the symptoms, reduce exacerbations, improve exercise tolerance, and overall health status. Now, am I going to alter the course of the disease? Unfortunately, not through these medications. And that has to be clear to you and to the patient as well. You're going to try to improve their health status overall, but the disease progression, this is not something you can control with these medications. So what are the medications available to us? Now, we have receptors in the airways. The first receptor I'm going to discuss is the beta receptor. So adrenergic receptors, alpha and beta, there's beta 1, beta 2, beta 1 on the heart, beta 2 in the bronchioles. And we found out once we stimulate the beta 2 receptor, the smooth muscles in the wall of the airway relaxes. So that leads to what? Bronchodilation. So we are going to call them beta 2 what? Agonist. Agonist because we actually stimulate the receptor. We don't block it, we activate it. So those medications have the ability to stimulate the beta 2 receptors. So we call them beta 2 agonists. Okay, some of those medications work for a couple of hours, 2 to 4 hours. So we call them short acting because they're not long acting. So then short acting beta agonist, SABA, SABA, short acting beta agonist. Now, if we come up with a medicine that is long acting beta agonist, we call it LABA, long acting beta agonist. Working on the same receptor but for a longer time. Great. So short acting like salbutamol, SABA. Long acting like formoterol, LABA. Beautiful. Side effects when you stimulate the beta centers or the beta receptors, yes, they are beta 2, but you can never be 100% specific. You can also stimulate beta 1 on the heart and cause some tachycardia and some tremors. And patients usually complain of that early on when you're not familiar with the side effects of the beta agonists. And I usually tell the patients, okay, if it's like mild and stuff, we can tolerate that. And it's actually an indication that the patient got the medicine in. Most of the patients, don't use good technique and the medicine doesn't go in. So I usually ask the patients, after you take the medicine, do you feel a little bit of palpitations or tremors? If they don't feel it, then I question whether or not they're using good technique. We found another receptor to work on, and that is the cholinergic type receptor, parasympathetic, and it is called muscarinic receptor. So if you stimulate the muscarinic receptor, you get bronchospasm because they make the smooth muscles contract. So that's something we don't like. So we can block those receptors. So we're going to use the muscarinic receptor antagonists. So what are we going to call this medicine? We're going to call it, short-acting or long-acting. First of all, we're going to call it muscarinic antagonist, MA, muscarinic antagonist. If it's short-acting, then it's short-acting muscarinic antagonist, SAMA or SAMA. If it's long-acting, it's going to be long-acting muscarinic antagonist, LAMA. So SAMA, LAMA, they both work on those receptors. They block the effect of acetylcholine. They prevent the muscles from contracting. Hence, we achieve bronchodilation. So that's the second pathway or the second method of relaxing the smooth muscles. Beta agonist, muscarinic antagonist. Nice. Now, we know the short-acting muscarinic antagonist ipratropium and long-acting muscarinic antagonist tiotropium, and many others, obviously. And then we came up, side effects of the long-acting or short-acting muscarinic antagonist. They worked exactly like atropine by blocking the acetylcholine effect. So dry mouth, retention of urine. You got to be careful with that in elderly patients who have prostate hypertrophy and retention because things can get worse. Now, someone said, okay, which receptor am I going to be working on? The beta receptors or the muscarinic receptors? We said we work on both. If we get 20% improvement on this receptor and another 10-15% improvement on the other receptors, why not combine both? So rather than using a huge amount of medicine on just one receptor, risking getting the side effects because of the big dose, why don't you use a little bit of medicine here, a little bit of medicine there, and combine the effect? So we said compliance is going to be an issue. If I give the patient two different inhalers, they say a muscarinic antagonist, a beta agonist, use them both, patients will not be compliant. So we said, okay, let's put them in the same canister. Mix these medications together in one canister and allow the patient to use one canister and get the double effect. So does that work? Actually, it worked, and it worked beautifully. And the effect we got from the combination medications is much better and superior to the effect we got from each agent alone. So we started combining the short-acting together, SABA and SAMA, like Convivent, which has the salbutamol and ipratropium, the SABA and the SAMA together. And we found that the effect is superior to using a single agent. Same thing when we combine the LABA and the LAMA. Also, we got superior effect from the combination medication. So it's a good medicine practice. So we started combining all these medications, LABA, LAMA, LABA, LAMA, and they're available commercially. And we said, well, can we combine the LABA, long-acting beta agonist, with inhaled corticosteroids? Now, what's the story of inhaled corticosteroids and COPD? We said COPD is an inflammatory disease, right? So the use of steroids is a good idea. Theoretically, yes. But let's try it. When we tried to use inhaled corticosteroids alone in COPD patients, we found that there is increased mortality signal. So people decided, we're not going to do this. Okay, so it's forbidden now. We cannot use monotherapy with inhaled corticosteroids in COPD patients. But if you combine them with long-acting bronchodilators, you don't see that mortality. You actually get the benefit. So fine. So you can combine LABA-LAMA, or you can combine LABA, inhaled corticosteroids, ICS. And again, they found that the combination of these medications work better than using LABA alone. I tried to summarize the evidence I got from the literature regarding the use of these medications. So number one, the regular use of inhaled corticosteroids alone is not a good idea. There is strong evidence for short-acting and long-acting bronchodilators. Combination, better. You start with one medicine. If the patient's symptoms are not controlled, you go to a combination medicine. You go combo. Now, which medicine is better for COPDers, LABA or LAMA? Which receptor helps COPDers better, blocking the muscarinic receptors or stimulating the beta receptors? They found that there is an advantage for the LAMA over the LABA. So my first preference is going to be a muscarinic antagonist before I prescribe the beta agonist, whether short-acting or long-acting. And then tiotropium was obviously found to improve lung functions and improve exercise performance. And when it comes to theophylline, we have some reservations because theophylline, yes, it is a bronchodilator, but the effective dose is so close to the toxic dose, and that's why we're a bit uncomfortable with theophylline, especially in patients who have cardiac history, arrhythmias and stuff, because people can get bad arrhythmias with it. So it is not recommended, and the evidence is B quality. There's a new player, which is called roflumilast, and it's been around for a number of years. And that works through a totally different mechanism. We said we have two receptors, beta receptors, muscarinic receptors. Now we found a third pathway to improve bronchodilation, exercise capacity, reduce the inflammatory changes within the airways. And that is an anti-inflammatory medicine called roflumilast. It works through the PDE4 pathway, which is specific for reducing inflammation. The evidence is pretty strong for that medicine, but the question is, who gets this? Am I going to start any COPD patient on this medicine? No. Obviously, those who have been tried on combination medications and did not respond, or those who are getting a lot of exacerbations with the idea that they might have some sort of inflammatory process that needs to be controlled with anti-inflammatory medicine. So the same concept as combining inhaled corticosteroids with the long-acting beta agonist. The same concept, but if the patient did not respond to this kind of combination, LABA, LAMA, ICS, then it's time to consider anti-inflammatory medications, either like macrolide long-term or roflumilast. So now the strategy is clear. We went back to the four squares to decide who is going to get what. And this is the summary of how we're going to treat. It's a little complex, but let me make it simple for you. We'll go back here. Actually, here, Group A. This is the person with the least amount of exacerbations and symptoms. Simple patient, mild or moderate. No exacerbations, gold criteria, stage 1 or 2. So how do you treat these patients? You can actually get away with a short-acting medicine. SAMA or SABA, take as needed. End of the story. All right. What about this patient? What is that? The B? Yeah. The B are the ones who have a lot of symptoms. But on the gold criteria, still mild or moderate. They don't get a lot of exacerbations. How do you control the symptoms? Obviously, short-acting medicine is not going to work. You need to start with your long-acting medications. You start with a LAMA or a LABA, your preference or the patient's preference, according to availability, price, patient preference, whatever. One medicine doesn't work, combine to two. Simple. What about the patient who is in the C box? What is a C box? A lot of exacerbations and advanced GOLD, but with less symptoms. I would say the same thing. Whether you're having exacerbations or having symptoms, then I need to treat you with a long-acting medicine. We start with a LAMA. And if LAMA alone doesn't work, combine. Combine what? Combine LABA and LAMA. Or combine with ICS. Because of the risk of exacerbations, maybe ICS would help. Now, this is the most complex patient we talked about, the patient who has a lot of symptoms, exacerbations, advanced GOLD stage 3 or 4. Obviously, I'm going to start and escalate quickly. You can start a LAMA and combine LAMA-LABA, and then combine LAMA-LABA, ICS. And then if that doesn't work, you're going to be thinking about other medications like long-term macrolide or even roflumilast, plus pulmonary rehabilitation, oxygen, non-invasive positive pressure ventilation, all these things. So this is the patient who's going to be the sickest of the four group. Now, as we said, you're going to be prescribing those inhalers, and you have to be cognitive of the patient's ability to buy the medicine or get it, insurance or non-insurance. It doesn't really help if you're going to prescribe an expensive medicine and the patient is not going to buy it. And then every time the patient comes to the office, especially when the patient says, I'm not getting better, you want to ask them, are you really taking the medicine? Are they adherent to the medicine? And are they using a good technique? And you can ask the patient, show me how you take the medicine. And you'll be surprised. You'll find out that more than half your patients don't know how to take the medicine. And even though you demonstrate to them in the office, they will forget. Anti-inflammatory medications, we just talked about inhaled corticosteroids and roflumilast, and somebody would say, how about the use of prednisone? And I'm saying, well, when the patients come to the hospital with exacerbations, we always give them steroids, oral prednisone or IV form of steroids. Why can't we do the same thing for patients at home in treating stable COPD? And then we tried that, and we looked at the studies. There is strong evidence A, that we get a lot of side effects. And there is maybe a lower level of evidence C, that we get no benefit. So why would I use a medicine that doesn't benefit and causes a lot of side effects? So the recommendation is don't use it. It's not recommended to use long-term steroid therapy, oral steroids for stable COPD. Mucolytics, if the patient has a lot of tenacious mucus and stuff, it would help this particular population if they're plugging up the airways all the time. The evidence is decent, B evidence. Statins don't really help COPDers, and there was a claim initially that statins are anti-inflammatory and they might suppress the activity of inflammation in the lungs and help COPDers. Well, it's been tried in the literature, and the studies showed that we get no benefit. So the evidence is pretty strong. Good studies, randomized controlled studies, statins don't help COPDers. So you don't have to use it just for COPD unless you're using it for other things, comorbidity with heart and other things. Leukotriene modifiers have been studied for asthmatics, and they're great medicines for asthmatics, but they have not been studied efficiently or enough for COPD patients, so the jury is out. We cannot make recommendations. At least we cannot advocate using leukotriene modifiers to control COPD. When the patient develops pulmonary hypertension, can I use the pulmonary hypertension medications for these patients? Well, the answer is no. Those medications are primarily manufactured for patients with primary pulmonary hypertension. Those patients who have secondary pulmonary hypertension, which is type 3, do not actually benefit from using those medications. The use of opioids is a great choice of medications because it alleviates the sense of dyspnea and improves overall health status. There's a warning here. When your patient is using a lot of short-acting medicine and not using his long-acting medications, I always tell the patients to convince them, because the patient is not convinced to use the long-acting medications. And the reason is very simple. You prescribe both. You say, this is your control of medicine and this is your rescue medicine. So use this every day, twice a day, which is a long-acting medicine. It's going to improve your health status, reduce your exacerbations. On the long run, you will benefit. But if you get in trouble with active bronchospasm, use the inhaler, which is the short-acting, because that is going to break the bronchospasm quickly. It acts quickly. Very shortly, the patient will learn to completely ignore and discard the long-acting medicine and just stick to the short-acting. The patient is thinking, why am I taking this medicine that doesn't really give me any effect or impact. I use it and I don't feel any different. And I use the short-acting medicine. To him, this is the rescue medicine. And I feel great. In a few minutes, I feel much better. So why would I use this medicine? I'm going to stick to the short-acting medicine. And to convince the patient of this strategy, I usually tell him, if you have a car, now, do you take the car to the shop for maintenance? Meaning like every 6 months or so, you take your car to the shop. And this is what happens. The car is running fine. I mean, there's no trouble. When you take it to the shop, they inspect it, change filters, oils, whatever they do in the maintenance, and then they give you a bill, you pay money, and they say, why am I paying this money? I mean, the car doesn't feel any different. The car was fine before I went in, the car's still fine when I came out, and I'm just paying money. But if your car is broken and it gets towed to the shop, and then all of a sudden it's working again, you feel the difference because the car was broken and now it's working. So I tell them this is exactly the control of medications and the rescue medicine. Control of medicine is like maintenance. In the long run, you will get benefit because your car will run better, the longevity will be better, and your overall health status will improve with this long-acting medicine. You're not going to feel it immediately. Like you never felt the difference when you took the car to the shop because the car was fine before and after. But this rescue medicine, just like when your car gets broken and gets fixed. So if your patient is using the rescue medicine more than twice per week, that means he's not controlled. And you need to improve your strategy on the control of medication, which is a long-acting medicine. Antitussives are not recommended. Long-term antibiotics like macrolide, erythromycin or so is beneficial. There is strong evidence that it does really help reduce exacerbations, but you have to weigh that against the risk of development of resistance to bacteria. There is good evidence, B-class evidence, that replacing alpha-1 antitrypsin in deficient patients does improve the patient's condition by reducing progression to emphysema. Now, who gets this therapy? Obviously, those who are developing emphysema or have a lot of exacerbations. Pulmonary rehab, even though it is not fully reimbursed by many of the insurance companies, it is a great tool in restoring overall health status and improve exercise capacity and reduce complications. The evidence is pretty strong and it reduces hospitalizations. Also, oxygen therapy has been well recognized. If used more than 16 hours a day, then it actually prolongs life. Only two things can alter the course of disease in terms of improving survival, and that is quitting smoking and long-term oxygen therapy. Only these two. Everything else is just treating symptoms and making the patient feel better. Now, if the patient is hospitalized or before the patient is hospitalized, you can use non-invasive positive pressure ventilatory support. And there is now growing evidence that you can actually keep patients at home and prevent hospitalizations if you use CPAP or BiPAP, especially for those patients who are hypercapnic or have combination of COPD and sleep apnea. Let's see the next slide. Yeah, it has become standard of care in patients who present with COPD exacerbation in the hospital because it does save them intubation. It might buy you time, a day or two, until the bronchospasm breaks or the infection is treated effectively, and you don't have to intubate these patients. So to them is a lifesaver. Now, if the patient has not responded to that therapy, now we're going to be thinking about something that is more advanced and more invasive. Now, imagine that there is a big part of your lung that is not functioning, and a sick lung emphysema that's just big dead space, not contributing to gas exchange, and it's occupying the space of the healthy tissue underneath that could expand and take that space and perform better. So we say, why not cut this area out and allow the healthy tissue to expand and take that place? And that's the whole theory behind lung volume reduction surgery. So it works best when that area of emphysema, or bulla as we call it, is in the upper lobes. That's what the literature showed. That's the best place. So if you cut off bully in the upper lobe, allowing the rest of the lung to expand, then you get these benefits. Patients improve their exercise capacity, and is recommended for those patients who are still severe, not responding after you've tried everything, all the medications, pulmonary rehab, they went once, twice, they're not improving, then it is time to recommend some sort of surgical intervention. And like we said, it works best if there is bullous disease of the upper lobes. Now, if the disease is spread throughout the lungs, there is no option because you don't know where they're going to cut. These are like little blebs here and there. Those patients are not candidates. But they might be candidates for something else. If the patient is not a surgical candidate because the patient cannot tolerate surgery or does not want surgery, we can still work on these big bully by a bronchoscopic technique, by putting in a valve in the bronchus that leads to this area. And this valve valve is a one-way valve. It allows the air to escape out of that area and not go back in. So over time, this area is going to collapse, as if we are removing it surgically, but we're removing it through a non-surgical approach. We found that the same thing. You allow the healthy tissue to expand and do a better job, and you would expect the overall health status will improve, exercise performance will improve, lung function will also be much better. So this is what the valve looks like, and this is how we are deploying the valve inside the airway. You go in there, deploy the valve, and the valve will work exactly like we described. The air is going to go out and not back in. All right, if everything fails, then you need new lungs. When is the patient a candidate for lung transplantation? When do you need to refer the patient for lung transplant? You better do it before the patient is very sick, because if they got so sick with comorbidities and stuff, they will no longer be candidates for lung transplant. So what you want to do is, if you see FEV1 dropping and like below 30%, the patient is not responding well to your treatments, pulmonary rehabilitation, oxygen, all that stuff, patient requiring more oxygen, this is the time to defer the patient for lung transplant. So patients who have very severe disease, so we said like below 30%, 35%, and obviously getting new lungs should improve the quality of life and functional capacity. But obviously it's a very complex way of treatment, and transplant centers will evaluate the patient thoroughly to decide whether or not they are candidates to receive new lungs. What if I cannot really do that and the patient is not a candidate for surgical or non-surgical lung volume reduction surgery, transplant, nothing worked? And you know the patient is on his last days and the patient's going to pass. You still have a role in making the patients feel better by providing palliative care. And palliative care focuses on patient's comfort. We could be providing oxygen, nutritional support, opiates to alleviate the sense of dyspnea, psychological support, and all that stuff. Don't forget that COPDers are also depressed because of the poor quality of life. And sometimes we forget that patients are depressed, and we think they're not eating because they are short of breath and cannot eat, have poor appetite, but many of them are actually depressed. So pay attention to depression and the treatment of comorbidities as well. Now, as you understand, November 16th is a COPD day, so still in November when we're listening to this presentation. So spread the word about COPD awareness. And I hope as frontliners and primary care physicians that you have benefited from this presentation. And I hope this will help you in trying to identify patients with COPD, refer them early to confirm a diagnosis in the pulmonary function lab, and initiate the treatment, understand the severity of disease, the risk of exacerbations, how you start therapy, modify therapy, how you escalate, how you can also use non-pharmacologic approach to treatment, when you refer the patient to a pulmonologist, and when you refer the patient for lung transplant or advanced therapy, either lung volume reduction surgery or bronchoscopic invasive techniques. Thank you very much. It's been a pleasure, and I wish you all the luck. Thank you.